highlighting the disparity between Aboriginal and non-Aboriginal people is actually very important as a focus of attention on this issue. What we do with that's a completely different story, but it actually is very important we get the evidence right around the disparity. What do we mean by the disparity? I think there needs to be some more work done around the thing like the different levels of health within the Aboriginal community, rural, remote, urban, very remote. What are the differences there? So I think once we get a bit more sophisticated and able to articulate those differences, we're able to focus where the effort should be. I think people have understood the connection between the social determinants of health for quite some time in the Aboriginal community. 30 years ago, Aboriginal people started talking about the comprehensive primary healthcare model that meant health is more than what happens in a doctor's surgery. We've been doing that for 30 years. The rest of the health system is just catching up now, particularly with this epidemic of chronic diseases that's starting to hit this country. So you manage chronic diseases differently than you do infectious diseases. So our mob for 30 years have been saying, they used to ask the question, why is a medical service looking at housing issues? Why is it looking at employment issues? Why is it advocating on behalf of someone in the welfare system? We knew then all of those issues impact on Aboriginal health. We just didn't know that they were called social determinants of health. We can't use a social determinants approach to actually slow things down. And there's a bit of a danger of that everyone will wait till everything's ready and then go in. And I think there's a view emerging within the CRC now is that you just do what you can do. And if you're a health professional, you do that. If you're an educationalist, you start doing that. At least you're making an effort. But you've got to understand the context in which you're working, and that is, people who are better educated enjoy better health. People who have a higher level of income enjoy a better level of health. But that shouldn't stop you from actually doing what you do. I think sometimes in Aboriginal affairs we make things too big and people walk away from it and say, oh, this is all too big. I don't know where to start. My advice is just start somewhere. Just do something. If it's in health, do it. If it's in education, do it. And then we'll work out how it all comes together in the end, because we all sat around, waiting for, the chicken and egg situation, waiting for one or someone else to make a move. Nothing will happen. And I think we've got to be really clear about that when we're promoting the social determinants of health process. Most CRCs fund PhD scholarships. We know we've got to create a pathway for our researchers. So, honours, masters, PhDs. We know we've got to pay a bit more money for scholarship stipends because most Indigenous people undertaking this sort of research and scholarship actually have a lot of commitments. So if you're going to give them $20,000, it's not going to work. So we give a fair bit of, our average of our scholarships is about $30,000 a year and they're tax-free. That's the sort of systemic change you can implement in a small way. And now, by us doing that, we've got other people looking at us saying, well, geez, can we do something different? So I think that issue of workforce is one, again, how do you encourage people in, we're very serious about the Aboriginal health research workforce because of the education of Aboriginal people in this country. We don't have a big resource there. We know we've got to do things differently to get that through. And it's the same with the workforce and doctors and nurses and people who will generally have power in a system. And the most powerful people in the health system, I think, are doctors. Whether we like it or not, I think that's what happens. So how can we get more people into there? How can we get the universities to provide a safe place for our students to go? How can we get the universities to provide an environment that they're not they can be students, that they don't have to carry the weight of the Aboriginal world on their shoulders, which we're finding now happens with some of our medical students. You know, they're in a cohort of about 300 students. There might be 1 or 2, 3 if they're lucky, Aboriginal people in that group. They're expected to have all the answers for Aboriginal health, when in fact they're there to learn, and we want them to learn. And so we've got to create, the universities have got a role to play here. How do we create these safe environments for our doctors and nurses, the physiotherapists, the pharmacists who are going to come through our schools of medicine? We're moving down that track, and we're giving people the opportunity to be powerful people within the health system. But that doesn't end there. You know, like, not everyone's going to be doctors and not everyone's going to be nurses. So how do we build the workforce? How do we empower people in remote communities to take some control here as well? And because the issues facing remote Australia are endemic across whether it's Aboriginal or non-Aboriginal communities, the inability to attract good quality people to these remote areas is well documented, and that's why we probably have the majority of doctors in those areas are people who come from overseas. So it's a long-term process. It starts with education. It starts with the health of an unborn baby in a mother's womb. Is the nutrition of the mum right? Is she smoking? Is she drinking? Is she going to give that child the best chance when it's born to actually be able to absorb all this stuff? So it's across the board, and again, I suppose I'm being a bit guilty of what I said that I shouldn't do, and that's make it too big. But again, it goes back to saying, well, if I do this bit right, I'm going to contribute over here. And if the deans of medicine do their job right in constructing safe spaces for our students, we're going to actually produce good doctors, and eventually they're going to have great health outcomes. We don't want the deans of medicine to fix housing up. We just want them to fix on one hand, more Indigenous doctors, on the other hand, non-Indigenous doctors who are sensitive to the needs of Aboriginal people. So they contribute that way. They contribute to housing, they contribute to education, they contribute to a whole range of other areas like income, but they're concentrating on producing good doctors, both Aboriginal and non-Aboriginal doctors. So I think that's important, that again, go back to that bit that I said before, do what you can do. We've got to think about Aboriginal medical services in a different way. I think we think about Aboriginal medical services being a vehicle for people to have a say in the health system. They have a say in the way that organisation specifically delivers services in an appropriate way. And more and more medical services are taking on the role of advocacies within the health system for not only in an Aboriginal health population health context, but for individuals. Like, we'll have medical services representing people to the hospital when they need to go to a hospital. So I think that we should think about Aboriginal medical services as a mechanism to engage with the Aboriginal community. And in that way, all the research in the world shows us when you get the recipients of a service being involved in the delivery and the design of the service, you're going to end up with a better service. And that applies whether it's Aboriginal or non-Aboriginal people. So I think we should think about medical services not only performing the need of a primary healthcare service, actually a mechanism for government to use as an engagement strategy with the wider Aboriginal community. And I think that's one of the most important parts, because whether Aboriginal medical services like it or not, they're actually part of the system. And it's about how they can influence that system from within and from without. And I think it's both of those approaches that we've got to take.